I'm Banu Arun from the University of Texas MD Anderson Cancer Center, and I would like to welcome you to our Spotlight number 16 session, Genetic and Polygenic Risk. So first, I would like to invite, who's already here, Dr. Fergus from the Mayo Clinic, Rochester, Minnesota, to talk about genetic and polygenic risk for breast cancer. He will be reviewing abstracts 01 through 05.
Okay, thank you, Dr. Arun, and the organizers for inviting me to be the discussant here for the first 5 abstracts, the first 5 posters. Thank you, everybody, for attending. I know we're way down the far end of the conference center, so you made a special effort to get here. We appreciate that. Okay, so I'll get started here. These are my disclosures. Okay, so the way I'm going to do this, at least from my section, is I'm just going to walk through the 5 posters. We have 5 to do in 15 minutes, so I'm really just going to touch on the brief points, the overviews for each of these different presentations. So the first poster is from the Myriad Genetics group led by Tim Simmons, who's on the stage with us. And this was really an attempt to take their multi-ethnic polygenic risk score that they've developed over the last number of years and apply it in a longitudinal validation in the UK Biobank. Okay, so the objective was a pre-specified longitudinal validation in that UK Biobank using this PRS. And the poster lays out what the MA385 PRS actually is, just as a quick overview. I think it's 59 ancestry informative markers and then a 300-odd breast cancer risk SNPs combined together. And it has been shown in previous abstracts and publications that this performs quite evenly across the different subpopulations. So here we're trying to validate it in the UK Biobank. So here's a very busy slide. I don't expect you to read it all. Approximately 200,000 women from the UK Biobank. We have time of enrollment to follow through to invasive breast cancer. We have therapeutic risk modeling, risk variables and risk models available. And so the therapeutic model was combined with the polygenic risk score, the MA385 polygenic risk score, as has been shown before by this group, to obtain what are called combined risk scores. So in this poster, what we're really trying to do is compare therapeutic alone against the combined risk score after we initially show some validation of that model. So this was done, the methods here, Cox proportional hazards, Kaplan-Meiers to look at 10-year risk thresholds. And then they also were able to look at subset. I think most people know that 95% of the UK Biobank is sort of a white European extraction. So they had a small subpopulation of non-white individuals, about 12,000 here that they were able to work with. So here are essentially the 2 main findings from the poster. The first one on the left is the calibration of the combined risk score in the white population and in the non-white, and we see a really nice calibration there on the graphic. And then next, they compared it to therapeutic alone. So the 5% here refer to the 10-year risk threshold that most people are familiar with. And so they're looking at combined risk score versus therapeutic when they're discrepant. This is the red line. When they're discrepant at the low end, this is the blue line here. And so what we actually find is that when the combined risk score shows a higher effect, it is actually the correct effect because they've got the longitudinal 5 or 10-year follow-up. So it does seem to be outperforming the therapeutic standalone model. So the conclusions are that we can combine this PRS with the traditional risk factors and provide a 10-year breast cancer risk prediction on the basis of this and then other prior studies. And so that's very useful just in terms of integration of this into the field. This is the one polygenic risk score that's commercially available in the United States. There are other countries that are now bringing in polygenic risk scores clinically. I just heard today that actually Brazil is just started up polygenic risk scores clinically. So we're seeing it starting to take hold, but there's still a number of implementation studies that are being done around the world, Australia, France, United States, et cetera, that are still trying to show the clinical efficacy of the polygenic risk score. So those studies are ongoing. They haven't read out yet, But for the moment, it is being used clinically anyway. And as you can see here, it's potentially a powerful addition to risk modeling. So that's the first one. The second poster is from the Mayo Clinic group. I have no involvement. This is from Amy Degdam's group, looking at the well-described benign breast disease cohort from the Mayo Clinic, and it's led by Dr. Lohani here. So the idea here is to take the polygenic risk score and apply it to individuals who have been found to have benign breast disease. And in the next slide, we'll show what versions of benign breast disease we're really talking about here. Sorry about the background noise. So in the past, the polygenic risk score has been applied to a consortium study of benign breast disease from a number of different studies. Now here, they're just trying to do the standalone Mayo Clinic only study and demonstrate associations with histologic lesions and then also with breast cancer risk. So we start off with 3,900 from the original benign breast disease cohort of 20,000. They have DNA samples on 3,943 women. They break these down into non-proliferative, proliferative without atypia, and atypical hyperplasia as the three subtypes of benign breast disease. And you might think of these as sort of progression events as you go along through the spectrum of benign breast disease. And then they ran a case control study on that, defining cases as the benign breast diseases that later had breast cancer. Controls are those that did not get breast cancer. So that's the comparison group. The genotyping came from a variety of different sources, oncoarrays, global scanning arrays, or Regeneron sequencing. And that led them to use 261 SNPs for the PRS. Classically, we all talk about the old BCAC PRS, which is 313 SNPs. Why do you get only 261 here? It's because when you sequence the DNA instead of using genotyping arrays, you can't actually recall a variety of those SNPs, a number of those SNPs, so you end up with 261 consensus SNPs coming out of sequencing. That's why it's a little bit lower there. So again, a busy slide here. The take-home message here is that, as expected, histologic impression was associated with breast cancer risk. So here we have, and it actually can be hard to see, but we have the three non-proliferative, proliferative with atypia, and then on the right-hand side, we have the atypical hyperplasias. And then we have essentially the controls and the cases in the two different colors. And you can see in each of the three different subtypes of benign breast disease, the PRS is higher in each of those case series. So there does seem to be an association with breast cancer risk in the future. That seems to be the way it's reading out. But you'll also notice that there's no real difference between these three subtypes. They're very uniform as you go across them. And so there's association of the PRS with breast cancer did not differ by histological category, which is a little bit unexpected. We would have thought maybe that the non-proliferative group, which is a very, very early form of benign breast disease, would not necessarily have read out that way differently to controls, but in this case it did. Then they also attempted to show the impression or the impact on risk itself. So in this case, they broke the data into tertiles, or broke the PRS into tertiles, so three groups, took the middle group as the standard and compared the low end and the high end versus that. And the lower tertile has reduced risk of breast cancer. The upper tertile has increased risk of breast cancer. But again, that did not seem to differ across the three subtypes of benign breast disease, which again is a little bit surprising. But the data speaks for itself in this context. So the take-home message from that is that potentially that PRS can be, or any PRS really, can be combined with benign breast disease as an added predictor of breast cancer risk. So it's nice to see that confirmation in the standalone study. It very much agrees with what's come before from the consortium study. So those are the two main PRS papers that we have on presentation today. They're both showing how we can implement or advance the use of PRS for risk profiling. Now we take a little bit of a transition. We move into a different area. This is more along the lines of understanding the biology behind risk, understanding and fine mapping of known loci for breast cancer, and finding new loci or genes associated with breast cancer. So this is presented today by Taylor Head, who's on the podium here, from the Bhattacharya lab. And Taylor, I believe, is a new postdoc in that group. So this is a nice opportunity for her to present this material. So what are the objectives here? This is a fairly technical and complicated poster. I'm not going to get into how they did it. I'm really just going to go the overview here. So they integrated genetic, so SNP-based data or mutations, with the isoform level transcriptomic data. So what's different here? So in many cases, we've taken SNPs and we've correlated them with gene expression, but that's global gene expression, the overall effect in a sample. Now they're looking at splice-based isoforms, each one individually, and trying to figure out if there's different isoforms that are really associated with the different SNPs. So that's an important part of it. They also, so what they find is that it improves upon the transcriptome-wise or the TWAS by accounting for isoform level expression. They look across 8 different phenotypes here. And then they assess the effectiveness of the TWAS in identifying genes and isoform associations. So again, here's a detailed slide with some of the findings. It increased, so this iso-TWAS, as they call it, increases discovery. So there's a big bump in the number of genes where they see unique associations in the TWAS, and in particular in breast and prostate cancer. So this really is a bit of a jump here. So it's quite effective. For that alone, it could be considered a very effective technique. Improved prioritization, they get 1,236 genes that are constrained gene associations. So that's nice to see that they're finding constrained effects. And then locus tagging, so they tag 52% more GWAS loci than gene expression alone. So again, it clearly seems to be a more accurate way of doing this. And I suppose we should expect to see something like this as we get more granular with our expression data. We should be seeing some of this. So it's nice to see this model giving us the results we expect. And then there's also heritability improvements. So they explain 63% more of the SNP heritability. And then in particular, in a couple of the different phenotypes that they study, breast, colorectal, and lung, they see specific isoform associations, so expression of different genes that were not seen when you just looked at overall expression, but when they go to the isoforms, these really strong associations for each of these phenotypes now show up with gene-specific expression effects. So here's, from my perspective, the main finding on the poster, where it's actually showing us the green ones here. So this is each of the different phenotypes across the bottom. The breast cancer is on the left there, and then they break it down into ER positive and ER negative. The sort of mustard-colored or yellow-colored bar are the genes that were identified by the iso-TWAS and the original TWAS. So these are common, so they're finding most of those. The red ones are only found by the original TWAS. So the iso-TWAS is missing very little. It's getting nearly everything. And then the green ones are all the novel ones that were found in the iso-TWAS. So there's quite a bump in some of these phenotypes, as you can see here. So an informative technique, I think. So what's the significance here? Well, I think it's the critical importance here is we should be modeling isoform-specific expression. I think that's the take-home message. It does highlight gene and transcript level expression levels that are important. So we have to look at alternative splicing as we look at phenotypes. That's very clear. But there are some limitations to the method, right? So there are the impacts of LD blocks on these isoform-specific effects that might complicate the identity or the identification of these things. Short read RNA sequencing, which is what most people do, may not be ideal for this sort of stuff. Long read RNA sequencing may be needed to really spot these isoform-specific effects. And so there's not a lot of data currently available that would be able to support this sort of discovery. But going forward, of course, it may be that we'll all transition over to the long reads. And then there's a lack of European EQTL data, non-European EQTL data sets, so it's quite limited in terms of its ability to discover in the non-white populations. But again, future experiments hopefully will fill in those gaps. So this is more of a technical advance, I think, showing us that how we might move forward with better gene associations and better understanding of mechanisms underlying risk. So now we transition from that more mechanistic paper, we transition to single gene effects, and now we're studying P53 and Li-Fraumeni syndrome. And this is really led by a consortium of investigators, Judy Garber as the senior author, and presented by Dr. Sandoval. So the intention here was really to take all the different P53 germline mutations that they've seen in people who apparently have Li-Fraumeni syndrome, in their consortium and look at the impact of the different variants on age and on breast cancer subtype. And the breast cancer subtype is defined not by molecular subtype, but by ER and HER2 status. So basically clinical markers being used to identify those subtypes. So here's the data set. It's 301 individuals. Sorry if it's hard to see. 301 individuals here. And they're nicely spread out by years of diagnosis. Age of diagnosis is quite young, as we'd expect. So this is breast cancer in Lee-Fraumeni patients. Age of first breast cancer is coming in at around 37 years of age, which we very much expect to see. They looked at the Lee-Fraumeni criteria in 3 different ways: attenuated Lee-Fraumeni, Champray only, and classic Champray. So really, they've broken it down. It's nicely separated out between these 3 categories. ER status, 66% ER positive. HER2 status, a bit of a mix between positive and negative, like 50-50 there. And then you can see the different subtypes by ER and HER2 status at the bottom, and a nice mix across those different subtypes, except for the ER negative, HER2 negative group, the triple negative group there. So now what do the mutations, the mutations in these 301 individuals, what do they look like? So here's a nice pie chart showing that they're predominantly missense mutations, but they do have some representation of large CNVs here, accounting for 6%, frame shifts, nonsense, and then alternative splicing. So again, there's a nice blend of the different types of mutations here, hopefully then giving us some more information about age and subtype status. They also looked at functional classification, and this was put forward by Christina Fortuno out of Mandy Spurdel's lab, working with this consortium a couple of years ago, where they defined these subtypes of P53 mutations. So we have truncating hotspots, missense dominant negatives, missense non-dominant negatives, and then unclassified variants. So again, a nice spread across all those different types of mutations in this data set. So that's nice to see. And here now we look at the missenses in the DNA binding domain of P53 versus the missenses in the tetramerization domain. And for instance, mouse models have shown that missenses in these 2 regions have completely different phenotypes. So now the question is, what's it like in the human setting? So we look at age here. There is a difference in age, 33 versus 41. So tetramerization domain, very much later onset in comparison. ER status, they're predominantly ER positive in the tetramerization domain. HER2 status, a lot lower positive rate, more negative rate. And then combined together, you can see that there's more ER positive. Having a hard time reading that. Sorry, there's more ER positive, HER2 negative in the tetramerization domain group. So 51% versus 34%, 35%. Okay, so there are clear differences in these 2 domains. That kind of goes along with what we already know. And now we're taking these functional categories that I just presented a couple of slides ago, and we're looking to see if we can see differences in age, ER status, HER2, and then those combined subtypes. And you can see the yellow bars here. This was nicely, appreciate this slide was provided by the authors. Here's the outliers, or the differences that we're seeing. So the missense variants that are not dominant negatives really do seem to be outliers compared to all the other types of variants. And you're getting differences in age at first breast cancer, in ER status, HER2, and then the combined data set. So again, there's an enrichment for the ER positives in this not dominant negative group, whereas the other subsets seem to have a lot lower level of ER positive. So a fairly descriptive abstract, but really quite interesting in that it really breaks down the functional categories of P53 mutations and shows how they perform in breast cancers within Lee-Fraumeni patients. So I think this will be quite helpful to a better understanding of these patients and what their risks are as they come into the clinic. Now the 5th abstract, yet again we take a jump and we go into a totally new field. So now we're into a prevention trial. And so this is presented by the Karolinska group, and Per Hall is here as the presenter. He's on the stage. And so this is really, I would call it almost a breakthrough discovery. This is a really important discovery in the area of breast cancer prevention. We're all familiar with tamoxifen as a prevention agent for breast cancer. But but we're all familiar with the side effects of tamoxifen and the fact that many women stop taking it or only take it for a very short period of time. So the search is on for other agents that can be used instead of this to bypass these side effects. So people have arrived and started looking at endoxifen, which is a metabolite of tamoxifen, downstream metabolite of tamoxifen, I believe below 1-hydroxytamoxifen. And in this case, in this study, they were testing whether the endoxifen, the application of endoxifen, reduced mammographic density as a surrogate for breast cancer risk, and then also looked at the side effects of that. So the study, in this case, Charisma Endoxifen is the name of the study. It was a 6-month, so a short window, double-blinded, randomized, placebo-controlled, 3-armed phase 2 trial. Now, the 3 arms are actually placebo versus 1 or 2 milligrams of endoxifen. So a nice trend in dosage available in this small study. 80 women in each arm. So hopefully sufficiently powered to observe some nice results. So interestingly, there were no differences in age, BMI, or other baseline characteristics in the 3 arms. So that was good to see. They're all nicely standardized. But there was and the most important thing here probably is that there was a significant reduction in breast density with the 1 or 2. And I'll show a couple of quantitative slides after this, but just overview is that there was a reduction in density with the application of endoxifen. So that's encouraging. The 2 milligram arm, which is a higher dose, was associated with more adverse events such as hot flashes and night sweats, and we'll show you the data on that. But there was no significant differences in the side effects when comparing the 1 milligram to the placebo arms. So I think you can see where this is going. There is a reduction in breast cancer risk. There's no increase in side effects. So we're arriving at 1 milligram as an effective dose here. Here's some of the data itself. On the right is previous data published by this group from a tamoxifen trial. So if we focus on the left with the endoxifen data, you can see the number of individuals, but then the density measurement is changing, and then the number of early terminators due to side effects, you can see that it's up to 13.8% in the 2 milligram, the higher dose. So it's obviously causing some significant complications for women. But the lower dose, 6.3, is really not different from the baseline 5. So that's great to see that we can dose with tamoxifen and really not have a problem. And then again, we're looking at some of the other features. So these are the side effects. You can go down through it. So in the tamoxifen data, that original trial in tamoxifen, almost every one of these variables shows up as significant in that setting, even at a lower dose of tamoxifen. But when you come into the endoxifen data, you only really see a couple of issues with the 2 milligram dose of the endoxifen. The 1 milligram seems clean all the way down through all these different phenotypes. So this is really very, very encouraging data from my perspective. So it looks like, as I said earlier, 1 milligram of endoxifen that does not seem to have more side effects and does reduce the breast density. So very encouraging. So it underscores the potential for that drug to be taken forward then in a larger breast cancer prevention trial. But further studies may be needed to understand that. I think that's a nice conclusion to my section. I'll now stop here. That was a general overview of these 5 posters. We'll now open it up, I think, to a Q&A session.
Yes. Thank you so much, Dr. Couch, for this wonderful and quick review. So now the floor is open for about 8 to 9 minutes for questions and discussions for the panel. I'm also monitoring online. Yes, please introduce yourself.
Thank you. Stig Bøjesen from Copenhagen University Hospital, Denmark. My question is for Per Hal. So you didn't look at breast cancer risk per se, you looked at changes of
a little bit closer, Stig. Closer to the microphone.
Yeah.
Yes.
So you looked at changes of breast density, but not breast cancer risk per se. What are your thoughts on breast cancer risk? Does endoxifen change that, or does it change only breast density? If you look ahead, we might need some kind of intervention when we do risk stratified screening to offer high-risk women. Would endoxifen, regardless of breast density, be an idea?
So Yeah, so the weakness of the study, you point out that. The weakness of the study is that we used as a proxy for therapy response density change. So you could say that in our previous study, we identified low-dose tamoxifen, it worked. In this study, we identified at 1 milligram lowest density significantly compared to placebo. But as I think you indicate, that's sort of half the way. So we also have to show that we decrease incidence of breast cancer in the old-fashioned way, randomize large number of women to placebo and endoxifen. That we have to do. And how we're going to do that, can't tell you because we haven't decided. We are discussing it. So yeah.
I actually have a quick follow-up for you, Dr. Hall. Do you think you would do a 1 milligram endoxifen versus placebo, or 1 milligram endoxifen versus 5 milligram tamoxifen?
Given our previous results, I don't think we will ever, in the preventive setting, we will never not go back to tamoxifen, no way. So the question actually, when we looked at the results, we were discussing when we set the study up, what doses to use, because so few individuals have been exposed to endoxifen. So now, in retrospect, I would like us, it would be a fantastic if we also had half a milligram. That would be, but we don't have that.
All right, a new challenge, half a milligram. All right.
Hi, so Sasha Hell from Manchester. I'm afraid it's another question for Per.
Oh.
How much heterogeneity did you see in terms of response in the mammographic density? So you've given a very nice sort of demonstration of a reduction overall, but the original data from IBIS-1 with visual assessment of density suggested that it was quite variable between individuals.
So there's a huge variation in response. There's also a huge variation in change over time, also for the placebo group. The person who developed this tool where we measure density and density change, because density change is not a trivial task to measure because all mammograms are taken differently, so there's different amount of tissue in the image, so they have to be aligned before measured. But Michael Eriksson is sitting over there, so you could talk to him afterwards.
So, I think the team in Manchester, not me, but demonstrated that your prediction at the second year, you may as well guess say it's going to be the same at year 1 before you get to year 2, because it's so difficult, as you say, to measure it.
Yeah.
Do you think it is going to end up being a good biomarker for efficacy of these drugs?
I think sometimes that we oncologists have to follow the cardiologists. They have been extremely clever in identifying risk factors for myocardial infarction, stroke, cholesterol and high blood pressure. If we could use, and someone asked me during the session, that why don't we treat density instead of treating risk, as cardiologists do. They treat a high blood pressure, which is not a disease, it's a risk factor. So maybe that's the way we should look at it. I don't know.
Brilliant. Great study. Thank you.
This is... Seema, you have to ask the other ones.
So I just wanted to congratulate you on what sounds like the start of a pretty exciting journey. So very nice data, good to see. But my question really is for Dr. Couch. And it's a general question that I think we all struggle with at some level, which is in terms of the utility of these PRS scores. And we see many reports, of course, that show small increases in the accuracy of the risk estimate by adding PRS. And the examples that we saw today, the benign breast disease example, there was a big overlap between the cases and the controls, even though the p-value was significant. So in terms of actually using this information, what is the best metric, do you think? One could think of it as a sorting tool. So then, if it's going to sort women into categories for interventions, that would be useful. But that requires a lot of data to find the threshold. So how does one approach this problem in terms of the utility and the implementation?
So your question is about how to identify the women who will benefit.
Mm-hmm.
So, the way we are thinking about the next study, where we'll test if endoxifen low-dose endoxifen lowers incidence, that's using an image-based tool. So you measure risk through the mammograms. Reason for that is that we have a breast cancer screening program in Sweden, which 70–80% of all women attend, and this image tool is fairly simple. It's not simple. It's not a simple thing to divide it, but to develop it. But it's easily introduced into the clinical setting. So once a woman comes for a mammography screen, you could immediately get her risk assessed. If you want to, you could add on some lifestyle factors and even genetics, as we've seen. But the way we're look at it now is you only use the images.
Sorry, my question was for Fergus.
Yeah, you're asking about the PRS as well. Yeah. I suppose I can try and answer this. You don't want to take it? No. So, I mean, the way I think of it is that it's another risk factor. It's certainly a highly quantitative risk factor, and I think we've seen enough studies now to show that it can be implemented, and you see this combined risk score that they've effectively shown now in a large validation study. So the simplistic way to use it is just as an addition to the Tyre-Cuzick model, and just implement that on a continuous score and use that 5% threshold to put women into higher or low risk categories, which might then have implications for aromatase inhibitors, tamoxifen, et cetera. But you could, I mean, there's many different ways to approach this, right? You could also, just categorize people for risk. And as I mentioned, there are a number of implementation studies ongoing around the world for PRS and how to use it clinically. So, I mean, I'm not the one to comment on this. Actually, Dr. Antonio over there might be able to give us a couple of comments on what he thinks we should be doing, but because he's integrating this into he talked earlier today about integrating this into large risk models. But it's a complicated business, and there's still some discovery to be done, I think. Antonis, do you want to comment?
Thanks, Fergus. Well, I mean, what I would say is that, in fact, what we see, the PRS is a much better risk stratifier compared to any other risk factor that we know in terms of traditional risk factors, the lifestyle or hormonal risk factors. So they don't stratify that population as effectively as a polygenic risk score does. So, to my mind, we should be using that if we want to identify individuals in different risk categories. Then that's it should be used. But there are a number of studies. There's many people here that there was a presentation, I think, for the Danish screening that she presented earlier as a poster. Kind of implementation studies of how we do that in practice. So there's a lot of issues that need to be resolved of how these are done. So there's a number of implementation studies that are looking into those as well. And I think many people, I don't want to name everyone here, but everyone here seems to be interested in implementing the polygenic scores. So.
All right, thank you. We are running out of time, but I'm just going to extend a little bit because we had 5 abstracts and we're going to have 3 in the second one. I would like to take one question from our online attendees and then you, and then we have to move on. So the online question is for Dr. Lohani. Thank you for the great study. How was ancestry handled in the study? If you can give us a brief answer.
Thank you for the question. So our population was mainly white women, so it is biased in that aspect.
All right, well, that was quick. Thank you. And last question.
2 quick questions for the first 2 people. The first one was, did you look, because I know the UK Biobank, did you look at people who've got BRCA mutations to see whether the polygenic score varies their risk of developing breast cancer? Because the Tyre-Cuzick doesn't really look at BRCA status at all. Do you have data on BRCA status to see whether that polygenic risk score varies their risk of developing breast cancer? And for Lohani, the question is, that polygenic risk score may have nothing to do with benign disease. Have you looked at a normal population? It may just be a risk score for breast cancer, but nothing to do with benign disease, because all 3 are the same, as Fergus Couch pointed out. Have you looked at a normal population of people who've got normal breast tissue to see if it gives you a risk of breast cancer as well? So those are my 2 quick questions.
Briefly.
Yeah, so we did not look at how our PRS interacts with BRCA1 or 2 or any of the other breast cancer mutations. We developed risk score for women who are negative for those variants, and so we restricted our population here to women who were negative for them. And I'm not sure I understood your second question.
Results for the second speaker.
So the question is, how did we handle the ancestry? So it was self-reported, and so the sample that we used for polygenic risk scoring is mainly blood, and around 800 people we used a buccal DNA sample. So we had a BBD cohort of patients, around 20,000 from 1967 to 2010. And then we followed up these women. And first we found the cases. That means the women who had BBD. Did I answer my question? Sorry. This might be unrelated to benign breast disease, that's correct, but that is the scoring system that we have in these women. And then, I'm sorry if I answered that question or not.
Perhaps we can do it after the session because we are running out of time. Thank you so much. Really interesting discussion. I would like to thank the presenters and our discussant, and would like to invite Dr. Reid and presenters for posters 0, 7, 8, and 9, please. Where's Dr. Reid?
Good evening. So I'll be discussing contemporary approaches to high-risk screening and prevention, and I'll be highlighting 3 top posters in this session. Okay, these are my disclosures. So we know that breast cancer is the most commonly diagnosed cancer among females, where 1 in 8 female will develop breast cancer in her lifetime, which translates to approximately a 12% average lifetime risk of 12%. There are non-modifiable as well as modifiable risk factors listed here in descending order, and we know that there are pre-malignant lesions such as lobular carcinoma in situ and atypical ductal hyperplasia, which is associated with an increased risk of developing breast cancer, as well as high breast density, which is also associated with a 1.5 to 5-fold increased risk of developing breast cancer. So these risk factors, including polygenic risk score, are included in risk prediction models, which ultimately calculate a patient's lifetime risk of developing breast cancer. And the development of these risk prediction models has now allowed us to identify high-risk patients with a lifetime risk of 20% and higher who would benefit from high-risk screening and prevention strategies. So here I have included commonly used risk prediction models comparing the elements included. For example, we see here that race is included in 2 of the models listed, and breast density is included in 3 of the most commonly used models listed here. Currently, as kind of, from the prior discussion as well, we see that a lot of these risk prediction models were not validated in racial, ethnic, minority groups, and moreover have been shown to underestimate breast cancer risk in non-European populations. So the first abstract looks at quantitative breast density measures and radiomic parenchymal phenotypes to improve breast cancer risk prediction among Black and white females undergoing screening. So to put this in context, we know that high breast density is associated with increased breast cancer risk, but may not capture important aspects of risk, such as the volume of dense tissue and the pattern of breast tissue. We also know that breast cancer is usually assigned by radiologists with poor reproducibility, and therefore quantitative radiomic phenotypes more accurately describe breast tissue patterns and is associated with breast cancer risk after adjusting for breast density. The top panel here shows two images with high breast density. However, figure A, which is the first one, displays a smooth texture, whereas figure B displays a complex coarse tissue. And in addition, we know that Black females are also known to have a lower breast density despite having higher volumes of dense breasts. And therefore, the authors here look to see whether quantitative breast measures, in addition to radiomic phenotypes, could improve breast cancer risk prediction, especially among Black women. The included females, 35 at age 35 and older, undergoing routine screening, where they had 1,055 cases and 2,764 controls, with 14% of patients self-identified as Black. The authors here showed that the incorporation of radiomic phenotypes did significantly improve breast cancer prediction beyond breast density alone, and that radiomic phenotypes improved risk prediction to a greater extent for Black females with an AUC of 0.69. The second abstract here looks at trends in lobular carcinoma incidence from 2000 to 2020 as it relates to the differing screening guidelines. So we know that early detection saves lives, and here I have included 5-year relative survival rates overall, independent of subtype, where we see for patients that have localized disease, when treatment is typically more effective and less extensive, we see that there are 5-year relative survival rates of 99%, and that drops to 32% for patients with distant disease. When we think about prevention in the context of the cancer control continuum, we know for breast cancer, for example, there are lifestyle modifications, as well as chemo for prevention and risk reduction surgeries, for example, for high-risk patients. And then when we look at early detection, we know we have screening for average risk patients, and then there's high-risk screening for patients that are identified as high risk from these risk prediction models. So the breast cancer screening guidelines here were recently updated from the U.S. Preventative Services Task Force earlier this year, where now the recommendation is to begin screening at age 40 every other year. And we know NCCN has always been, for quite some time now, annual screening that begins at age 40. You'll see here listed below the high-risk screening guidelines, which recommends breast MRI beginning at age 25. So the objective of this abstract, the second abstract, was to determine if variations in the incidence of lobular carcinoma in situ correlated with changes in screening guidelines. And here you will see that the incidence of lobular carcinoma in situ has increased from 2000 to 2020, and the higher incidence was noted when the guidelines recommending screening at age 40, which was between 2002 and 2009. You'll see in the purple, it dropped off when the screening guidelines had changed back to age 40, but as I just mentioned, now we have gone back to age 40. So I would suspect that we will start to see higher incidence of LCIS now that the screening guidelines have actually now recently been updated to starting at age 40. The third abstract looks at a decision support intervention to promote the use of preventive therapy among women at high risk for invasive breast cancer. So as mentioned in this section here, we know that risk reduction surgeries, and I think this was a focus actually even yesterday, we know that there are risk reduction surgeries, both prophylactic mastectomy as well as bilateral salpingo oophorectomy, as well as medications such as selective estrogen receptor modulators and aromatase inhibitors that can be used as prevention for patients identified as high risk for developing breast cancer. However, we know that these strategies are not without side effects, and therefore there is definitely a need for us to refine our risk assessment strategies, but also to improve our risk reduction options for patients where we're able to increase the efficacy, tolerability, quality of life, because these drugs are not without side effects, and also to, in considering healthcare-related cost. So then when we think about prevention option, it's really a discussion between that individual patient and their provider to really review the benefits and the risk of the different options that are available. So here, the authors here tested a decision support tool comprising of an educational video and graphic display of benefits of preventive therapy viewed by patients prior to their clinic visit. And here they included 48 high-risk females that had a history of lobular carcinoma in situ or atypical ductal hyperplasia, where 21 patients were in the implementation group. And here the authors found that the majority of patients were unaware of the benefits of prevention options to reduce the risk of breast cancer despite good health literacy. And the decision support tool reduced the number of patients unsure about preventive option, but oddly enough, increased preference for not starting treatment. So what are the lessons from these three abstracts? We see that starting screening at age 40, which we know and I hope will now stay this way for some time, will increase the incidence of pre-malignant high-risk lesions. However, along with that, we will need to also increase education for risk reduction strategies and high-risk screening for prevention and early detection. We will also need to prioritize risk communication and decision support tools to increase the uptake of prevention among our high-risk patients. And lastly, I think incorporating these novel radiographic tools to risk prediction models in a diverse cohort is not only feasible, but also improves breast cancer risk prediction. So in conclusion, we know that refining breast cancer risk prediction models has the promise of improving the identification of high-risk patients across diverse populations. And we know that patient as well as provider education of prevention options is needed with increasing incidence of pre-malignant high-risk lesions with earlier initiation of screening. And then lastly, prevention and early detection strategies translates to improvement in survival rates. We have seen that over and over, but also quality of life when we're able to offer patients less therapies earlier on, as well as reduction in overall healthcare-related costs. Thank you.
Thank you so much, Dr. Reid, and thanks so much for staying on time. The floor is now open for questions, either here or online participants. I can start with the first question while people are getting to the microphone. For Dr. Jackson, I thought the finding is very interesting that obviously the tool helps potential prevention candidates to be less unsure, but once they know and are informed, the uptake is low. And I want to phrase the question carefully, but also would like to quote Dr. Pierre Hall, where he said a few minutes ago, we will never go back to tamoxifen. So do you think it's, obviously the tool is very helpful, but do you think the problem is tamoxifen and maybe endoxifen, or, and I don't know if you in your data set included 20 milligram discussion or also the 5 milligram, but perhaps it's the agent? Any insights?
Yeah, I think that's a really good question. Thank you, Dr. Arun. I think it's the agent in general, because what was unique about our population is they are they have very high levels of health literacy to begin with. So patients that typically come to MD Anderson, they know what they want. The minute they walk in the door, they already have done their homework. And so exposing them to this amount of intervention, giving them this website with images to tell them exactly by how much tamoxifen or any of these interventions would decrease their risk of breast cancer, and also having these videos. The videos included women who were breast cancer survivors and taking these interventions themselves. And one of the feedback that we got from the patients was that they felt the video and the intervention in general was tilted towards preventive therapy. So I think the decision intervention itself did a great job promoting these interventions. But once the patients know exactly what their benefit is, how much risk reduction they're going to get, and whether or not they have a survival benefit, it becomes very clear to them that they do not want to get this treatment. So I think it's more of the agent, and if we have something that has more minimal, I mean, we typically say the side effects are not that much, but for patients it's significant. They pay attention to the details. Right. And so I think if we have something that is like baby tam, maybe we should sell that a little more. Maybe the newer agents will make a difference. But yeah, that's something that we still need to do some work on.
I can see a great collaboration with you and Dr. Hall on his 0.5 milligram endorphin he's dreaming, planning to do.
Yeah.
Thank you.
Thank you.
Any other questions, comments? I know this is the last session of the day and it's really late. If not, we can close just a few minutes early. And thank you so much for staying with us. And thank you again to our presenters and our discussant. Thank you.